Hi, good afternoon. Welcome everybody. This is Michelangelo Mancuso. I'm one of the two co-chair of the mitochondrial working group of the EURO-NMD. And this is the third webinar that we are organizing in September to celebrate the Mitochondrial Awareness Week that every year run in September to raise awareness on mitochondrial diseases. So today it's my great pleasure to introduce Professor Mika Martikainen from the University of Oulu, Finland, and University Hospital. Oulu University and the HCP as well are strongly involved in the ERN activities. They are member of the EURO-NMD, of the R&D, and also EpiCare. Mika is a great experience in research and science, also in the management of mitochondrial disease patients. And he took this challenging talk today to explore with us. So the topic of today is the pregnancy, how to deal with pregnancy on mitochondrial diseases. And during the webinar, you can, of course, put your questions in the chat, and at the end of the presentation, we will have time to answer to your question. So enjoy the webinar, and Mika, please, the floor is yours.
Thanks a lot for the kind introduction, Michelangelo, and thanks for the opportunity to present here. So let's get to the presentation. Okay, now I hope you can see the first slide, right? And now the slide changes, right?
Yes.
Yes.
I think it's fine.
Okay, very good. So let's get going. So as in the introduction, you heard the topic of today's presentation is pregnancy in mitochondrial disease. The outline is I'm going to talk to you a little bit about mitochondrial disease as an introduction, an overview of some basic things about what's going on there and about the genetics of mitochondrial disease, and then we will go through perhaps some things about genetic counseling regarding mitochondrial disease, because it's obviously very closely linked with the reproductive decisions in patients and families affected by mitochondrial disease. And then we will go through some of the things and the published data we have and some unpublished data shortly as well about pregnancy in mitochondrial disease. So as you all well know, mitochondrial disease conventionally refers to genetic disorders that affect the mitochondrial respiratory chain function and thus the production of ATP for the aerobic energy needs of the cell. So in a broader sense, one could say that mitochondrial disorders could be everything that has to do with some sort of pathology or dysfunction of some mitochondrial functions, but this is usually not the way we use this term, but rather those genetic conditions that in some way are intimately linked with the energy production and ATP production defect. So there are also other obviously important mitochondrial functions. Mitochondria are closely involved in calcium signaling, in the regulation of apoptosis, production of steroid hormones, production of ROS, and so forth. Both mitochondrial DNA and nuclear DNA variants can cause mitochondrial disease. So mitochondria are under dual genetic control, and this is why it's a bit more complicated with genetics and particularly genetic counseling and prognostication of possible effect to the next generation, particularly when we are talking about the mitochondrial DNA. Mitochondrial disease is a rare condition, and even as a whole, we talk about mitochondrial disease as rare disorders. But I always like to say that mitochondrial disease as a whole is a common rare disease, in the sense that we know from many epidemiological studies and work done both here in Finland and particularly by colleagues over in UK and colleagues in Italy who have done a lot of epidemiological work. We know that the prevalence is not so little. So in the adult population, in several European populations, the overall prevalence of mitochondrial disease is something like 9 in 100,000. So not that extremely rare at all. When we go to the details of mitochondrial DNA inheritance, so as you all know, mitochondrial DNA is inherited maternally, and this means that basically all maternal relatives with a pathogenic mtDNA variant, they are carriers, and they can present, or so they possibly can present with a phenotype related to this. But in details, this is a bit variable. There are multiple mitochondria in every cell, and within every mitochondria there are multiple copies of the mtDNA, and this is important as a background for some of the particularities of mitochondrial disease inheritance. One important or two important aspects in the inheritance of mtDNA are the bottleneck effect and mitotic segregation, referring to the fact that only part of the maternal mtDNA is transmitted to the offspring, and not only the ova are variable within the mitochondrial DNA content, but also the mitochondrial DNA content may vary and varies between tissues. So, for instance, a patient might have a different amount of a certain pathogenic mtDNA variant in the muscle tissue compared to the let's say heart tissue or brain tissue or pancreatic tissue and so forth. Heteroplasmy refers to the fact that for several pathogenic variants, they are usually not present as in 100% of the mtDNA as homoplasmic variants, but rather in some percentage. So both wild type and variant mtDNA are present, and this affects the phenotype severity in the sense that the higher the amount of the pathogenic variant, the higher the risk and likelihood of having a clinical phenotype, and also having a more severe phenotype when we go to higher levels of variant heteroplasmy percentage. Threshold effect is something that's well described for many pathogenic mtDNA variants, and this is very important also for the sake of genetic counseling. So this means that usually for the pathogenic variants, you need a high enough level of the pathogenic variant to produce a phenotype. This means that you might have a person where the pathogenic variant is detectable. It might be as a very low percentage, a few percentages of the mtDNA content. It's detectable, but it probably doesn't produce any phenotype at all for the individual during their lifetime. Then when you go up to higher percentages, the likelihood of having a phenotype increases, and also the severity increases usually with the amount. But because of the variability of transmission to next generation, people who may be themselves clinically completely healthy might then, when they harbor a pathogenic variant, they might then have offspring, they might have children who then have a more severe phenotype because they have a higher percentage of the variant. So a bit complicated, but very important to in order to understand the intricacies of how we deal with these conditions. So this image shows you or illustrates the mtDNA bottleneck. So from the mtDNA content in mother. So here the red where you would have the variant mtDNA. So the germ cells ova of the mother, the content of the pathogenic versus wild type variant, they differ, and this results to the fact that when a person like this would have several children, the mtDNA content in these children is usually variable, and then some can be completely healthy, some might be at risk of transmitting the variant further, and some might be even severely affected. Usually we know that there is a purifying selection for the in the sense that those germ cells with extremely high variant content, they do not proceed forward. So these are selected against. And we also have to keep in mind the nuclear genes, which are in the sense of genetic counseling, more straightforward and more along the classical Mendelian genetics. So the important examples of nuclear genes that are related to mitochondrial disease phenotypes are, for instance, POLG. Then you might have the TWINK gene, OPA1, MFN2 mitofusin related to mitochondrial dynamics defects and so forth. POLG is one of a very common form particularly in some European populations, a very common cause of nuclear mitochondrial disease. So the challenges in genetic counseling in particularly mtDNA related mitochondrial disease, as discussed before, we know that there is often variation between the ova in mtDNA content. Siblings can be very variably affected. Some can be completely healthy, some can be severely affected. So within one family, it's not easy to predict how these things will develop. Also, because of the tissue, heteroplasmy levels can be and are often variable. With one tissue sample, it's not always easy to predict what will be the complete clinical phenotype of an individual when they grow up. And also if we take, let's say, if we measure in white blood cells, we measure the heteroplasmy level of a mtDNA variant in an individual. So with the same percentage heteroplasmy, the clinical symptoms can be variable, and even in some sense the clinical severity of the phenotype can be variable, and this makes obviously things much more complicated. However, luckily we have been able to develop technologies which we will go through slightly in the following slides to increase the possibilities of women who have heteroplasmic mtDNA variants to have healthy children. So usually it's recommended that reproductive counseling for women with mtDNA disease should start very early, because the options for can become with aging, they can become more limited. So this is, I think, one of the key points for young women who harbor mtDNA variants to start thinking about reproductive counseling early enough to have the time window open for these discussions and family decision making and going through the individual options and individual wishes for family. Usually, it's very useful to assess the heteroplasmy level of an pathogenic mtDNA variant in different tissues, because we know for various variants the levels, for instance, in white blood cells, in urine epithelium or buccal epithelium can be, or muscle derived mtDNA, they can be very different, and even if possible, to test maternal relatives and if relevant affected offspring, to obtain a complete picture of how the variant, particularly when we are talking about the not most common variants, where the understanding of how this behaves might be little more limited than with the most common pathogenic variants. We know that in some instances the inheritance, the variant may rise de novo. This is possible. It's not that common for mtDNA point mutations, but it's possible. And obviously, as an obvious point, it's important to keep in mind and reassure male patients that they are not at risk of transmitting mtDNA variants to their offspring. So this is fairly obvious, but important to keep in mind in counseling, because this might not be that obvious to the families affected. So going through some of the precise techniques. So prenatal diagnosis by CVS or amniocentesis is one of the options. So we know that for several common variants, the heteroplasmy levels, they tend to remain stable in the approximately after 10 weeks of gestation, and prenatal mtDNA testing can be done for CVS or amniocytes, but they should not be performed on cultured cells, because the heteroplasmy levels can change during cell culture, and then the results are not reliable anymore. The limitations is, as discussed, the correlation between variant heteroplasmy level and disease severity. They are not always very straightforward. And obviously, when we are talking about homoplasmic or usually always high heteroplasmic variants, we have several of these, like for instance the common Leber's disease LHON variants and some MT-ATP6 variants they tend to be always homoplasmic or close to homoplasmic, and obviously here there is no it's not very useful to do the prenatal diagnosis, because we tend to know the answer already without testing. So we also know that when women who are clinically healthy and have undetectable mtDNA variant load in blood, they usually have a very low risk of affected pregnancy anyway. Another important thing to keep in mind is that the large-scale mtDNA deletions, which is an important group of adult mtDNA disease, these tend to be sporadic, and we know from studies already decades ago that the recurrence risk in families is actually low. And this is obviously, it's important to stress these sporadic large-scale mtDNA deletions are completely different from the secondary multiple mtDNA deletions that may arise due to nuclear mitochondrial disease, as for instance a secondary twink or POLG mutations. So this is a busy table from a study by Nesbitt and colleagues already a decade ago, just to sort of illustrate the how things might be very variable. So here we have a family or mother with the 91762C variant in ATP6 gene, and here the variant was not detected in mother in blood or urine, but in the offspring there was a very high level of heteroplasmy, and for another sample a low level of heteroplasmy, which is likely not to cause a clinical phenotype. So illustrates the high variability that and this has obviously implications for the continuation of pregnancy if one wishes so, and the prognostication of having a healthy or a clinically affected child. Pre-implantation genetic diagnosis, or PGD. So here we quantify the level of pathogenic variants and then decide where to proceed. And this is applicable when we know that there is a critical threshold, and we can approximate the threshold of particular variants of causing a severe disease expression in the child. So this is sometimes a bit difficult to decide, and this is why PGD is useful only in specialized centers where comprehensive family investigations can be undertaken, and where there is as much experience as possible with the decision making and counseling for the families. Also, we have to keep in mind that this is only a risk reduction procedure, and also only suitable for cases where there are also oocytes with a low mutant load. To illustrate the latter point, so here we see, for instance, oocytes with the 8993T2G variant ATP6 again on the B panel left, where you can appreciate that the level of heteroplasmy is constantly very high. Whereas for the common Miles, the 3243 variant, where there is a wider variability in the heteroplasmy level, and you can have oocytes with zero or very low levels of heteroplasmy, and these are obviously much more suitable than for PGD guided approach. Then shortly, this is something obviously very exciting, and most of you have heard about mitochondrial donation or mitochondrial replacement therapy, but this is something we because of time we can't go to very much details, but just to basically mention, there are now several methods of mitochondrial replacement therapy, where the basic idea is that you have the nuclear DNA content of the mother with the mitochondrial variant, and then you have you replace the mitochondrial DNA content from a donor, basically to produce a combination where the mitochondria are not from the mother, but the nuclear DNA content. So the vast majority of the genetic material is from the mother, and this creates an opportunity, particularly for women with pathogenic variants, where there is a high heteroplasmy in the level in the mother, and very high likelihood of having affected offspring with the other available methods. There is also the possibility of mitochondrial genome editing. This is not in human clinical use yet. So there are some questions which are at least partly unexplored or unanswered yet. So we don't know about the haplogroup effects, so whether the mitochondrial content or the mitonuclear interaction, whether this is affected when the mtDNA comes from a donor. So there has been suggestions that these should be haplogroup matched, so that the mother and the donor would have the same mitochondrial DNA haplogroup, so to minimize the risk of having some sort of negative effect of mitonuclear imbalance or mitonuclear incompatibility. There is a risk of carryover mtDNA and reversion, so that you might end up having still some of the pathogenic mtDNA in the offspring. Obviously, this is clinically extremely limited today, and one can conclude that obviously much more experience and research is needed before this is something that would be even in Europe widely available as a clinical approach. But very exciting, and obviously, as you all know, so very important pioneer work done by the group in Newcastle, UK, with this. So to go a bit quickly through some of the switching gears a bit, going to the pregnancy and how mitochondria and mitochondrial energy production, why they are relevant in pregnancy. So we know, which is obvious, pregnancy increases the energy requirements, the basal metabolic rate increases. Also, there is more thermogenesis, there is a bit more active energy expenditure and so forth, and placental function is critically important for successful pregnancy, and ATP, mitochondrial ATP production is very important there. There are lots of physiological changes during pregnancy. We know placental mitochondria, they are critical for a healthy pregnancy. Increased ROS production is related to risk of both preeclampsia and gestational diabetes mellitus. So this is part of the basic background for the importance or the risk of risks involved with defective mitochondrial function during pregnancy. So there are several pathways that link mitochondrial function and or mitochondrial dysfunction and placental dysfunction. So ROS production, there is elevated apoptosis, there is the decreased energy production, and also this in future this leads to inflammation and other negative effects in the cascade further on. In preeclampsia, which obviously we know a very high risk condition in the during pregnancy. This is not that uncommon. Defined as new hypertension and substantial proteinuria after 20 weeks of gestation, and mitochondrial dysfunction is closely implicated in preeclampsia. So in the systemic response in the pathogenic cascade, we know, just as a very rough overview, there are hypoxia, oxidative stress, other things, probably epigenetic genetic factors related to this, and in the end, inflammation, endothelial dysfunction leading to preeclampsia. And there's also more direct evidence of mitochondrial pathology in preeclampsia. Yeah, there is a reduction in mtDNA content, increase in glycolytic enzymes, which indicates a shift towards glycolytic metabolism, and so forth. But let's move forward to what we know about how things are in women with mitochondrial disease. So there are actually not that many studies on this topic, or not that many cohort studies where there is direct evidence of how even observational evidence of how things are. So already more than a decade ago, a systematic review identified some 10 case reports, and at that time, no cohort studies on this topic. After that, at least 3 important cohort studies have been published. The first was already 2015 by De Laat and colleagues, the Netherlands, the Nijmegen group. And after that, the Newcastle group published a study in 2019, and very recently, Sanchez, Lechuga et al., and this was from Ireland, Dublin, a study published in Acta Diabetologica. So let's go through these a bit. So if we look at the number of individuals in the studies, so in the Dutch study, there were 60 women who were identified from a 3243 patient cohort. This was a questionnaire-based study, and they had heteroplasmy levels of the individuals. The study by Catherine Feeney and colleagues, this was a retrospective case comparison study. This was also questionnaire-based, so meaning that there was no direct access to patient hospital data or medical report data, and there were similar amount of affected individuals, 67 women with confirmed mitochondrial disease, and most were with the 3243 variant. In the most recent study from Ireland, this was again a retrospective survey. Here they also did a partial hospital chart review on pregnancy outcome and glucose control, but not a complete chart access during the pregnancy. And here they went through 88 pregnancies of 26 women, and most were again with 3243. Here summarized a bit these 3 studies. So you can appreciate the number of pregnancies very similar in all studies. Gestational diabetes was present in 1 in 10 to 1 in 5 approximately among these subjects. Premature delivery was fairly common, particularly common in the UK study, and C-section. This is obviously something not only, as you know, related to strictly medical factors, but also slightly cultural things related to C-section prevalence for deliveries, but fairly similar figures, I would say, from 15 to 30%, highest number in the UK data. I would like to show you a bit some of the preliminary data from our own in Finland. This is data we have presented as an abstract, and we have a manuscript submitted on this data, but not completely published data yet. So we looked at 25 women, and among these, so roughly half were confirmed carriers of 3243, and half were maternal relatives, close relatives, so obligatory carriers, but in whom no direct DNA testing was performed. And we reviewed 75 pregnancies during close to 3 decades, and we did a patient chart review for each of these pregnancies for the cause and complications of pregnancy, and also the delivery and neonatal morbidity. Heteroplasmy level was 51%, very variable from 0 to 76, and the data was, as mentioned, not available for all of the subjects in the study. Gestational diabetes was present in 22%. We observed pregnancy-induced hypertension or preeclampsia in 13%, and preterm delivery in 12% of the pregnancies, and probably of interest that 12% of the newborns needed treatment for some period in the neonatal intensive care unit. So obviously much more than in regular population. We also summarized our findings that women with the 3243 probably have an elevated risk of obstetric complications, and the newborns probably have a higher risk or elevated risk of need of ICU treatment, and which is obviously following from these conclusions that the pregnancies of women with 3243 should be followed very carefully. Looking at, if we look a bit at the pregnancy complications in the published studies, there seems to be an association with the high heteroplasmy level with the premature delivery compared to term deliveries. This based on the Dutch data. Gestational diabetes seems to be more common, and the similar finding in the Irish most recent data with the prevalence of 24% here, and also preeclampsia seems to be more common, and in the Dutch data the risk of preeclampsia was not found to be related to heteroplasmy levels. In the UK data, so a normal vaginal delivery was observed only in 50% of the women. So this is something which is obviously of interest, but in a retrospective data, one can argue that it's difficult to say in detail of about the causes or the proximate reasons for why this has been the case. They also in the UK data noticed that the children they tended to be born at earlier gestations, and the birth weights were also lower than in comparison groups. Also similarly in the Irish data, the more than 13% of the pregnancies were premature, but here the mode of delivery was not different from the general population, which is again possibly hinting that there might be other things than directly related to the medical condition in the mode of delivery, and also a higher miscarriage rate, which is obviously concerning compared to background population in the Irish data. So what about the nuclear DNA variants? There is less published data. We don't know about these even that much that we know of mtDNA variants. There is a fairly recent study on Polgy disease where they found that pregnancy had a negative effect on the clinical course of the mitochondrial disease in the mothers. Particularly, there was a risk of disease exacerbations in the second trimester, and particularly, as you know, in Polgy disease, epilepsy and seizures are fairly common, a very common phenotype in Golgi disease, sometimes leading to very treatment-resistant status epilepticus. And they thought that the estrogen might be functioning as a proconvulsant here. But as said, so there is very little data, published data, particularly on this, and obviously more research needs to be performed. Some conclusions. There are, to date, few cohort studies. I think there is the limitation of relying on self-reporting data. We know very well from several sources that there are systematic problems in all studies when we rely on self-reporting data, some systematic biases, and obviously also the level of the granularity, the level of detail in the data is not as good when we don't have access to the direct patient data. We would need to have more direct data, particularly on the pregnancy follow-up, deliveries, early infant health, which is of importance here. As a general problem in rare conditions like mitochondrial disease, the problem is that everywhere the cohorts tend to be fairly small, and this is why I think international collaboration and possibility of creating larger networks and larger cohorts, larger international collaboration to have a more clear picture and better understanding of these conditions would be very important. One thing I would like to raise is the patient and family perspectives. Obviously, when we are talking about the pregnancies and reproductive decision making, so these are of very high importance, and this is something I would argue we know too little about, and this is something we would need to work on more. Some take-home messages from the studies. So I think we can fairly safely argue that particularly with the very common 3243 variant mtDNA, the Miller's mutation, there is an elevated risk of complicated pregnancies and deliveries. We don't know as well about many other mitochondrial DNA variants. The risk, particularly with some variants, might be smaller, particularly with those variants where the clinical phenotype tends to be more limited. Typical example would be the Leber disease variants, for instance, where the phenotype tends to be much more limited, or the 1555 A to G, which is related to sensory neural hearing loss and usually not a broad phenotype. So these might be obviously very, very different, but again, more data is needed. And counseling of at-risk women is important, and obviously careful follow-up of pregnancy is recommended. This is from a very recent publication, some practical suggestions. These are from a bit modified from this publication mentioned. For all of these, the evidence base, I don't know if it's really that strong, but for me these seem to be reasonable. Obviously, preconception counseling is important. Baseline assessment of the clinical condition in the patient, to discuss the prenatal diagnosis options, a lifestyle optimization, medication review to have an optimal condition for the pregnancy. This is important, particularly with individuals with anti-seizure medication. Is obviously of high importance to review the medication and make it safe for the pregnancy. Folic acid supplementation is recommended, and also gestational diabetes screening with an early glucose tolerance test at 20 weeks was recommended in this study. So earlier than the usual care screening time point. Fetal growth surveillance is recommended. also important that vaginal delivery is not contraindicated and should be the first option. So I think this is also reassuring and an important point. Regional anesthesia if C-section is needed. So regional anesthesia is better than general anesthesia if possible, and breastfeeding should be supported. And obviously one needs to pay attention to fatigue, particularly if this is relevant with the mother phenotype. So just to sum up this very brief overview on the topic, some future challenges and questions. I think individualist counseling and pregnancy follow-up of women harboring pathogenic mtDNA variants is very much needed and important. More work needs to be done. I would argue we need more natural history data. We would need also hopefully prospective studies. This is obviously not an easy task, but anyhow, even retrospective, more natural history data is needed, and if only possible, international collaboration would be very good here too. I think we will need to know more about the priorities and concerns of the affected women. This is something we know too little about. And also what factors affect the reproductive decision-making in families with mitochondrial disease. This is also something we know too little about and would be very useful to look at in future work. Thank you for your attention.
Thank you, Professor Martikainen. Very nice and interesting discussion on the topic, which is not easy, and it's a rare topic. So we have surely need of expertise, and the rare expertise that you share with other experts in the world is certainly very useful for our webinar attendees. At the moment, I don't see any question on the Q&A or on the chat, but we have Serenella Seviday that has just risen a hand, and I'm going to allow Serenella to unmute herself and put her question. Welcome, Serenella.
Welcome, Antonio. Very, very interesting, I think, and useful, because also if we have a small data, it's very important to give to the patient a few number on the risk. And I have two questions. One about the mitochondrial donation, because in Italy, the association of patients are strongly push to obtain this specific law from the government. But I think there are some risks that are not so small. Like when you take the nucleus from the mother, as you said, you can have still some mitochondrial DNA, some mutated mitochondrial DNA. And there is also a risk of the expansion of the mutation later. So do you think this is a serious risk or not so important to be afraid of this methodic? And another small question is about vaginal delivery. Don't you think that in mitochondrial patients with intolerance to exercise, this is stressful and can be dangerous too? Thank you.
Thank you, Serenella. So first, I have to admit that I don't have that deep expertise in mitochondrial donation. I haven't been involved in any of the so closely involved in the clinical work done by the group in Newcastle, who are the pioneers here. I agree with you that there are some concerns regarding this procedure, which are obviously there is a theoretical ground for these concerns. I think obviously all the children born with this method, we need to follow through very closely also to the future to see how things are, and we are, I think, waiting, if possible, we are waiting for future follow-up studies reporting how things proceed. Obviously, I think this is not going to be like a silver bullet for all families. I think it's probably going to be only for very, very selected population where there is, let's say, there is a mother with a high heteroplasmy of a pathogenic variant, where there is a very low possibility of obtaining PGD oocytes with low heteroplasmy, and who are adamant about having own biological children, and who otherwise are suitable for or there is no risk for carrying through successfully pregnancy and so forth. I think this is a limited group. I think for a larger group, you have other options which are more straightforward, easier, and this is not going to be for everyone. But I think it's for a limited group. It's obviously very interesting, and it provides for certain families an option that's otherwise not possible. But anyway, very relevant points. The other thing you asked, I think, obviously, if you have a more clinically affected individual with let's say more clear exercise intolerance, clear mitochondrial myopathy, things like this. So it has to be individual, case-by-case decision, which is the safest mode of delivery. We know in general there are several benefits for the child with vaginal delivery, benefits also for the mother. So I think with a high risk of exhaustion, for instance, so obviously then it's probably safer with C-section. But so basically the diagnosis of mitochondrial disease per se is not contraindicative of vaginal delivery. Decisions have to be made on the whole and in the end, case by case.
Also, because I saw in your slides a very high percentage of cesarean in emergency.
Yes, I think so. There were very different figures actually in between centers. So I think there are probably things also related to general attitude about C-section. We know in even like globally and even in Europe, there is a wide variability in the likelihood of C-section. So both from the side of obstetricians and also from the side of the mothers and families, how they perceive it, and I think there are also sort of paramedical or cultural things related to this. But this is it's obviously a bit speculative. I think we don't have exact data to answer this. But relevant point.
Thank you very much. Very interesting.
Yeah, you're welcome.
So a follow-up question from my point of view would be, C-section is liable to be inflated by attitudes and preferences, but the number of neonatal admissions to the ICU is not. So from your Finnish cohort, you presented that 12% of the births ended up there. So was the reason premature delivery? Was the reason low weight? Is that something that you have in your data or not?
Yeah, we don't have actually. We haven't looked at it or we weren't able to look at it in that close detail. So there are both the things you mentioned are there. So when you have lower APGAR scores and things related to the well-being of the newborn, this is one group, and also prematurity, which seems to be, and I think this is obviously related to the fragility of placental function, which seems to be, I think, a general feature in all these cohorts. There is a higher likelihood of premature birth and also issues for the newborn related to this. I think this is an important thing and important factor there, and this is probably very directly related to the mitochondrial dysfunction, which makes the placental function more fragile.
Good. So I think that your lecture was very interesting, and I appreciated particularly the slide with practical measures and ways of doing a proper monitoring of this patient, that is, of these pregnant ladies, that is different from the other ones. So, but the thing that basically pops up in my mind is that we are in dire need of an international registry of the pregnancies of these patients. Do you know of anything going on? Is there any progress on that, or what? How do you think we can make a difference and have some international collaboration to answer these questions that are in need of a larger cohort?
Yeah. So I am not aware of any international, at least in Europe, any international collaboration on this. There are currently, I think. For us, but at least in Finland, some legal aspects related to sharing patient data internationally, and this makes in some instances the international collaboration work a bit more tricky than it was before. I think from my personal perspective, I think for us the ERN collaboration, the ERN registries are a very good way, and this is for us also a legally solid window from which we can try to address this, and because within the ERN collaboration, it's for us it's legal to share data to the ERN registries, and this is also, I think, it's part of the rights of the patients as citizens, of having access to trans-border healthcare within EU, and I think I would be very happy to participate if we could, if other people also would feel this is useful and there is a need for this. I think it would be very good to create an international collaboration and possibly also prospective access to or creating a prospective cohort partially in addition to the retrospective data, which is also stronger when we can have a bigger number. So definitely I would like to see this happening, and hopefully I've convinced you all that is something worthwhile.
So food for thought, and hopefully we can start some discussions in that sense. I think it would be a good achievement. So we are approaching the hour. Thank you very much to all that have been present. Thank you to Serenella for important questions. Thank you to you, Mika Martikainen, for the excellent webinar. And it's all for today. Please, those who have not given us the feedback related to this webinar, I would encourage you, and on the chat there is a link that you can use. I would encourage you to fill the form and tell us what you thought about it. Okay. So thank you very much, everybody.
Thank you, Antonio. You too. Thank you.
Thank you. It was a pleasure.
And we'll talk soon, I'm sure. Bye-bye.
Bye-bye.